Thank you again, Paul, for inviting me. I am so excited to share with your audience tonight on a very, I feel like it's a complex topic for some, and so I try to break it down as simpler as I can. Actually, let me start from the beginning. Okay, can everyone see the screen okay?
Yeah.
Okay. I'm just changing my settings. All right, so let's get started. So this evening, I'll be talking about Doppler application in our fetal heart screenings. We'll go over some indications, timing, and most importantly, we'll go over techniques. Now, just a few of the objectives. By the end of this PowerPoint, you'll be able to understand some indications for why you would use Doppler in your fetal heart exams. And then you will be able to identify optimal timing for the Doppler evaluations. You will definitely be able to master some techniques and settings for your spectral, pulse wave, color, and power Dopplers. And then you'll be able to apply those best practices to evaluate key fetal cardiac structures and flows. From there, you'll be able to recognize abnormal Doppler patterns and their clinical implications. Okay, so let's get started. Now, first and foremost, Doppler ultrasound is, I feel, is a very important an essential tool in our fetal heart
It's not
assessments.
really working just yet, but
okay. All right. Can you show me how you use it?
Oh,
sure.
were you saying something?
Give me a demonstration.
Oh, someone's.
Okay. You did take the other side.
All right. Thanks for that. I think there's a few things we could improve upon that would let you get more effect from the medicine.
Please, can you unmute yourself? Please, I'm trying to. Okay. Lashell, please, can you unmute yourself?
Okay. Can you hear me now?
Yeah. Sure.
Okay. All right, so let's go back. So Doppler ultrasound is very important, and it's an essential tool in your fetal heart screenings and assessments, especially dealing with the fetal echoes. And so it allows us to visualize blood flow, measure velocities. We're going to assess this cardiac function. And by doing that, there's four major types that we use. That's the color, power, pulse, and spectral Dopplers. Now, each one of these offer very unique benefits and applications. And so we're going to go through each one, okay? Now, just before we touch on each one, I want to go over just some key advantages for each and then its best use case in fetal echo. Now, starting with color Doppler, its key advantage is flow direction and mapping. We're going to take a closer look at that. But with color Doppler, you're able to detect your septal defects with the shunting that it will show. You'll be able to assess valve flow and then the overall heart structure. Now, power Doppler is my absolute favorite because of its high sensitivity and it's less angle dependent. Now, this one in particular is especially important for those smaller vessels or the slow moving vessels. And it really enhances those vessels. And then pulse Doppler allows us to have that precise velocity at a specific site to detect the valve inflow and outflow. From there, we have spectral Doppler, which is known for making that waveform made from the pulse Doppler assessment. And so this will allows us to get the function and detect valve disease, and especially important, pick up those arrhythmias. Okay. All right. Now, before we break down each one, what are some clinical indications for fetal Doppler use? Why will we need to apply it? Now, of course, first and foremost, if you detect that there is some type of congenital heart defect, you want to use Doppler. In cases for intrauterine growth restriction, it's especially important as well. Abnormal heart rhythms, increased nuchal translucency or absent nasal bone or any other chromosomal markers. Maternal conditions can require you to use clinical assessment of the fetal heart by using Doppler. And then in cases of suspected fetal anemia or high drops. Now, before you apply your Doppler, you want to first start with grayscale or 2D anatomy so you can avoid some misinterpretation, okay? All right, so color Doppler here. Here's a beautiful example of color Doppler being used to assess the septum. We're going to go in further to talk about the ventricle septal defects that we can see and the particular shunting that we're able to see. But first and foremost, we're just kind of getting an introduction of each, okay? Now, the purpose is to provide a visual overview of the blood flow and how it works. It assigns the flow direction and velocity. So I provided a scale where you can see above the baseline here, the flow towards the transducer is all in the red color. And then below the baseline is flow away from the transducer, which is the blue and green colors. Okay. Now, once again, to reiterate, screening for this will be for abnormal patterns across the valves. We can see regurgitation, turbulence, and then across the septum, we're able to detect those shunts. Okay. Now, here's my special favorite one, power Doppler. Power Doppler is going to really enhance these structures, especially the smaller vessels or the slow-moving vessels. Now, how it works, it displays the strength amplitude of Doppler signals from the moving blood cells rather than velocity or direction. This one is still showing some direction in this case because I turned it on just to see the difference in where the direction is going with the blood flow, okay? Now, a key point with this one in particular is its high sensitivity to the low velocity flow. And so you're going to see later on when we take a look at some case studies how power Doppler in particular really enhance some diagnosis that color Doppler will not. All right, now pulse wave Doppler, this is one where we're going to measure the inflow velocities. So we'll measure the velocities of blood in a certain particular location. In this particular, what we're seeing here, we're measuring the velocities of both the mitral valve and the tricuspid valve, which you can see. Okay, now the uses here, it's measuring inflow. And then if we were measuring the aorta, of course, that would be the outflow velocity, okay? Now, from the pulse wave Doppler is where a spectral Doppler waveform is formed, okay? Now, this one in particular will really visualize and quantify the blood flow velocity and pattern within the fetal heart, the AV valves, and major vessels. Now, you can see the three examples that I have here. The top one is an example of a tie index. Here is an example of a ductus venosus waveform. And then here is an example of tricuspid regurgitation, all seen with the spectral Doppler. Okay. All right. All right, now what are the key cardiac structures that we're evaluating during our fetal echo? And so I list all of the key cardiac valves, and then what are we assessing with Doppler? So once again, with tricuspid and mitral, we're assessing those inflow patterns. With aortic and pulmonary valves, we're assessing the outflow velocities. Ductus venosus is going to give us the cardiac dysfunction, and it's an early marker of some things that could be going on that we can't quite see yet, especially in the first trimester. Okay. Foramen ovale is going to give us flow direction and presence. Pulmonary veins is going to give us that confirmation of connection to the left atrium. And then the aortic isthmus and the ductus arteriosus will give us the postductal velocities. Right? So they all are very important assessments that we have to monitor. Okay, now before we start to monitor, we have to change some settings on our machines. And so you want to adjust your scale in PRF. You want to adjust this to prevent the A-listen. If you have it too low, it may be too much flow. If you have it too high, you may not see enough information. So you want to keep that in mind. Wall filter, you want to lower for your venous flow. Your sample gauge size, you want to have it narrow for a precise measurement. And with your color gain, you want to avoid over gaining because that's going to obscure some flow pattern. All right. Now, when you're assessing for your arrhythmias, your sweep speed, you want to increase that to really get a precise measurement for that. All right. Now, always begin. This is a practice that I really prefer to follow. You want to always begin with color Doppler to just kind of before, and this is after you already looked at 2D, because remember, we start with the grayscale. But once we already look 2D, then we want to always begin with color Doppler first, just to get your orientation. Then you'll switch to power Doppler, especially if you're looking at smaller vessels or slow-moving vessels. From there, you're going to apply your pulse Doppler. You can see the sample gate here. And then hit set or run, and that's where you'll apply this, or you'll have this spectral Doppler waveform. And you see in this particular case, there was flow reversal of the A wave of the ductus venosus. All right. Now, when are you going to use the Doppler during pregnancy? First and foremost, routinely, you're going to use it at the 20-week scans, whether that's at the start of 18 weeks to 22 weeks. So your routine fetal anatomy scans, you want to use Doppler. We use Doppler at the first trimester screenings. So we're starting there. And in cases for a follow-up for congenital heart defect, or if you notice there was an abnormal heart rhythm. And then in some cases, you'll use it in the third trimester in those high-risk pregnancies. All right, now there are some abnormal Doppler patterns that you have to be familiar with. Now, we saw earlier where we had a reversal of the ductus venosus A wave. And so we'll go closer into what's a normal ductus venosus waveform coming up. But for now, here is what a reversed A wave would look like, which you can see SD and then a reverse A wave below the baseline. Another abnormal pattern is a pulsatile umbilical vein. So this is a intra-abdominal pulse, and it's showing pulse, where you should not see that in the umbilical vein. And then here is a free floating example of a pulsatile umbilical vein. We also have an example of tricuspid regurgitation seen with the color Doppler. We have mixed match here happening where it should be forward flow in both vessels. Instead, there is some reversal in the aorta. We'll take a closer look at that. We have that case coming up. And then here is an example of no flow present in the left ventricle. Okay, so these are all abnormal Doppler patterns. All right, now we're going to start off with first trimester. Did you know that between 11 and 13 weeks with the tricuspid regurgitation, it's often seen in cases of trisomy 13, 21, and 18. 80% of the trisomy 21 cases will show an abnormal ductus venosus flow. That's whether it's absent or if it's reversed. And then the tricuspid regurgitation is especially common in trisomy 18, and that's due to the tricuspid valve issues. Okay, so let's take a look at how to assess for these markers in the first trimester. Now, here in particular, it's following Fetal Medicine Foundation guidelines of how to acquire for tricuspid regurgitation. Now, this window of this assessment is done between 11 weeks and 4 days through 13 weeks and 6 days. Okay. Now, you want to follow these guidelines, especially if you're considering certification that they have. You want to follow these to the T. But first and foremost, you want to magnify the fetal thorax, which is seen here. And you want to really assess and get this good 4-chamber that they're showing. And upon placing your sample gate, you want it at about 2 to 3 millimeters right across the tricuspid valve. Okay. Now keep in mind that angle must be less than 30 from the septum, and that sweep speed needs to be 2 to 3 centimeters per second. Okay. And then from there, we're assessing for tricuspid regurgitation. Now, regurgitation is present if it's greater than 60, which you can see in this particular case, it's about 80, and that it is half of at least half of or greater than half of the systole, which we have here. It's just about half of that. Okay. But this is how you were assessed for tricuspid regurgitation. Right. Now, at the top one, this is a normal assessment where no regurgitation was present. So I do want to point that out as well. Okay. All right. Now, the same apply for ductus venosus. It's a couple things that are different. Once you're getting a mid-sag view of the fetus trunk, and you're assessing the ductus venosus right at the portion where you notice that there is some allicin. That's usually where you want to place that sample gate. I have where you can see here at the bottom as well. You'll place your sample gate there, and you want to keep the size of the sample gate, because it is a narrow section, to about 0.5 through 1.0 millimeters. Okay. That angle must be less than 30 degrees. Remember your filter at low frequency, and then the sweep speed is the same, which is at 2 to 3 centimeters per second. Okay. Now, once you assess that, a normal waveform should present as this: triphasic with S, D, and A above the baseline. Okay. But what we're evaluating, we're checking for if it's absent or if it shows reverse. All right. Now let's look at a few examples of abnormal ductus venosus. So starting with the reverse A wave, you see where we have both that S and D above the baseline, but then notice the A is below the baseline. So this was an example of a reverse A wave, which is abnormal. And then in cases where the A wave is completely absent, you won't see it. So you see you have the S, the D, and there is an absent A wave, which is also abnormal. Okay, so these are could be considered markers. So approximately 80% of down fetuses will present with an abnormal ductus venosus. So if you have a case where you have a thickened nuchal translucency or absent nasal bone, then I think it's a great idea to assess for ductus venosus waveform. And even tricuspid regurgitation assessment wouldn't hurt either in that case. All right, now here are some normal pictures that I took of a first trimester screening. All of these are required at the checklist. All aren't seen here, but all on the checklist is required doing every first trimester screening, whether it's high risk or low risk. We do for all of our patients. So we acquire a 4-chamber view, LVOT, RVOT view. Cardiac axis is only done if we suspect that it is off axis. We do routinely see the 3-vessel trachea view, aortic arch, descending aorta, IVC, SVC. Ductus venosus will just do like a color picture. We don't assess on every patient. And umbilical vein and ductal arch. Okay, so all of these are normal pictures. And let's take a look here. Now, here are some abnormal findings, all from first trimester. Now here, just to reiterate, we're showing again a normal 3-vessel trachea view and 3-vessel view. But everything else seen here are abnormal. I had particular at the first trimester, the aortic isthmus appeared slightly narrowed. With this particular case, I was able to follow all the way until delivery. And so this is a progression of aortic coarctation from the first trimester into the 3rd trimester, which it was confirmed. Okay, we also have a case of an aberrant right subclavian artery. So that's that extra vessel seen below the trachea, which you can see here. We had a confirmed case of overriding aorta, just there. Here again is another case of an aberrant right subclavian artery. Which you can see here, this is usually only seen with the power Doppler. So that's that special technique and uniqueness of that power Doppler. It's able to highlight this extra vessel. And then here is a case of a right aortic arch and left ductus seen in the first trimester. This actually was twins. And baby B, I believe, had the right aortic arch. Okay. All right. So now we're going to get into some applying, making the invisible visible, Doppler in action. Okay, I'm excited for this one. Now, color Doppler screening for flow pattern and direction. Power Doppler, once again, is going to detect the low velocity flow seen in those small vessels. Spectral and pulse Doppler will quantify that flow, velocity, resistance, and timing. But be careful, because with these Dopplers comes artifacts. So we want to watch for these artifacts like aliasing, motion interference, angle errors, and color bleed. Okay, so let's take a look. Now for valve function, when we're assessing the valves, we're assessing the tricuspid, the mitral, pulmonary, and aortic. The indications usually is for suspected regurgitation or to rule out stenosis or turbulent flow. Okay. Now the benefit with color Doppler is that it will highlight the jet of that regurgitation or any abnormal flow, while the pulse and the spectral Doppler will quantify that velocity. So that's going to show us with the regurgitation, if it's greater than 60 centimeters per second, we'll see that in our spectral Doppler waveform. Okay. Now with the Doppler use, you want to start with color Doppler. You want to localize the flow, then apply your pulse to get your spectral Doppler waveform through that valve. Okay. There is artifact with this one in particular, aliasing at high velocities or overestimation if that Doppler angle is too steep. Okay, now a quick fix for this, just increase your PRF scale, lower that baseline to reduce the aliasing, but keep in mind you want to always keep your angle less than 20 degrees. And then in cases like for the ductus venosus or so forth, use a smaller sample gate. That may help as well to fix that artifact. All right, now here's the examples again, as we had seen earlier, assessing the pulse wave Doppler of the mitral and the tricuspid valve. I want you to pay especially attention to the A wave assessment here. We're measuring the A wave, and there is a reason why we measure that A wave. So we're going to take a look further. Okay, now normal A wave assessment of the mitral valves going to range between, at a minimum of 31 to a maximum of about 75.8 centimeters per second. Okay. Now the tricuspid valve minimum and max is between 33 to 76. Now you always want to assess the tricuspid valve. Normally is going to have a higher A wave velocity than the mitral valve. Okay, so just keep that in mind. All right. Now, what are some Doppler patterns and what would they indicate when we're assessing these valves? Now, first, starting with the mitral valve, if you have an altered EA ratio or you notice that there is some abnormal peak velocities in the mitral valve, this is especially associated with your hypoplastic left heart syndrome or critical aortic stenosis. Okay, so that usually indicates some kind of obstruction on that left side or impaired left ventricle fill. Now, vice versa, if you notice that there is something going on the right side, you may see either reverse or a blunted EA ratio or waveform or some holistic regurgitation. This usually indicates pulmonary atresia with intact septum, which is associated with a hypoplastic right ventricle. Okay, so any abnormal Doppler finding on that side suggests right-sided obstruction or volume pressure overload. Now, what if you assess both sides to be abnormal? Now, in that case, that's usually seen whether it's a dilated cardiomyopathy or hypertrophic cardiomyopathy, and even seen as some extracardiac settings, whether it's fetal growth restriction or in some cases, gestational diabetes may show this. Overall, it reflects a global ventricle dysfunction on both sides. Okay. All right, now let's look on the aortic and pulmonary valves. Now, these both range in between about 60 to 80 centimeters per second. Okay, and then the grayscale with both of these, you want PV open or close, and close, color Doppler assess. PW is going to measure that. The PW is going to measure that velocity. Keep in mind the pulmonary valve velocity is normally less than the aortic valve. Okay, so that's a normal setting. Now, in cases where things are abnormal, starting with the aortic side, that's usually a result of a critical aortic stenosis or coarctation of the aorta. And then if it's abnormal on the right side, it's pulmonary stenosis or indicative of pulmonary regurgitation. All right. Now, where you place your pulse sample gate matters with what you're assessing. Now, when you're assessing for regurgitation, you want to place that gate proximal in atriums, which you can see in the example here to show regurgitation. Now, if you're assessing for this normal valve flow for that EA ratio or for a monophasic of what the aortic and pulmonary will show for those velocities, you want to place your gate distal within the ventricle at the leaflet tips to assess and get those waveforms. Okay, so those are just techniques to remember. All right, so here's that case that I was referring to earlier. We had a case of a patient, a late transfer. These are some of the pictures that were acquired from the exam. As you can see, it is a third trimester case. Right away, you notice the enlargement of all of the chambers throughout the heart. And looking at the heart before we apply color, who would have thought that there would be absent flow there in the left ventricle, which you can see here. So there was absolutely no flow there seen in that left ventricle. When we assess here even further, we notice a thickened valve here. You see the flow kind of set in here where we assess the pulse and spectral Doppler, where we had very high velocity seen from this mitral valve. And then, of course, you see the reversal there in the aorta. So this particular case was of Turner syndrome with a critical unicuspid aortic stenosis. Status post balloon, had a small aortic isthmus with the arch reversal, hypoplastic left heart spectrum, had left ventricle thickened, mitral valve, low velocity uniphasic flow. These most likely may progress towards hypoplastic left, 6 in 1,000, potential risk for hypoplastic left heart syndrome. So it showed where, in this particular case, all 4 of our Doppler settings were very useful in the diagnosis of this particular case. They all work together to give us a diagnosis. Okay, so this here is just showing with critical aortic stenosis, you're going to have in 2D a thickened dysplastic aortic valve, possible left ventricle hypertrophy. We see there a spectral Doppler tip. You're going to have that high peak velocity, which is seen. Once you see that, you want to check for retrograde aortic arch flow, which we do see. Okay, just some technique tips for you guys. You want to, if possible, because we're all at the mercy of the fetus, it's helpful to get these views at an apical 5 chamber or long axis view and align the Doppler beam parallel to the aortic outflow. And then keep your color gain optimized in the PRF settings to visualize the turbulence scene. All right. Now, here's a case of pulmonary stenosis. Now, pulmonary stenosis, 2D appearance, you'll have the thicken or domen of the pulmonary valve. And then you'll see that right ventricle hypertrophy if severe. Okay, now some color Doppler clues that are mentioned is the turbulent flow across the pulmonary valve, which we can see here, into the main pulmonary artery. It's even going into the ductus arteriosus down to the descending aorta. Now the spectral Doppler tip, measure the peak systolic, which that's what we're doing here. Align the Doppler parallel to the RVOT. You can see that velocity there. Now the technique, if you can, especially if fetus allow, you want to have get this possibly in the short axis RVOT view, your ductal arch view and long axis view. And once again, optimize that PRF and velocity scale because you don't want to over compensate for this blood flow that we're seeing. You want to really document what's really there. Okay. All right. Now this is it's a comparison of the stenosis and regurgitation and how it would appear with the color Doppler. So you know the difference between the two. Okay. Now for pulmonary regurgitation, the 2D appearance will have the valve thickened and show that insufficiency with some dilation of that right ventricle. Now, color Doppler clue, which is very critical in this diagnosis, you're going to see that backward flow into the right ventricle, which you can see for regurgitation. For stenosis is more, you'll see more of that allicin turbulent flow, and the difference there between the two. All right. Now for regurgitation, you want to assess the velocity, which is shown here with the spectral Doppler waveform, and just to check to see its duration. And also keep in mind correct angle for accuracy. All right. Looks like that technique is that short axis RVOT view is the best view. And don't forget to align the Doppler as parallel as possible to that regurgitation jet. All right, so let's get into arrhythmia. Arrhythmia assessment, especially used for cases of a slow heart rate or a fast heart rate, or even in cases of heart block. Now, the benefit of pulse Doppler, it's going to distinguish the atrial beats from ventricle beats, very helpful. Pulse and spectral Doppler will show the inflow, outflows. Color Doppler will help visualize the motion of the valves and the timing. Now, of course, we have artifact with this one in particular, especially if baby is very active. If baby's moving around, it can really cause some artifact. A quick fix, wait until fetus is still, adjust your sweep speed for better rhythm tracing, and reset that baseline, okay, to center that waveform. Now let's take a look at how to assess for a heart block. You'll assess for a heart block by doing a PR interval. PR interval is routinely done at my office because we have a lot of cases of mothers with SSA antibodies or lupus patient. And so we're routinely doing PR intervals throughout her entire pregnancy. It's very simple. Just you want to get a nice 4-chamber view just like that. And you want to place your pulse Doppler sample gate right at where you're almost going to get like the 5-chamber view, exactly as it's seen here. When you hit set for your spectral Doppler waveform, you will have this particular waveform come. You'll have the mitral valve showing the inflow, and then you'll also see the aortic outflow, which is seen below the baseline. Now, how to measure on our machines, we do have a PR interval button. We hit the button, here's a caliper. We place in between the E and the A wave, which is here. A second caliper is placed at the onset of the aortic flow. You hit set and you'll get your reading of 117 meters second for this particular one. Normal velocity is less than 150. Okay, so and that's how you'll assess for PR interval, okay, in cases of heart block. All right, so now we're going to look into structural congenital heart disease and why this is the one in particular where we'll look at the shunts that we'll see for VSD in particular. It's really helpful that the color Doppler will show the direction of the shunts. Now, before we go over to our case, let's take a look at the artifact seen in this particular one. Is color bleed. So this is where you have to really turn down your color gain so you won't miss the crossover, the shunting across the septum. Power Doppler may be too noisy in this particular one, especially assessing for VSDs. So you probably want to use the color Doppler instead. Okay. A quick fix tip, lower your color gain until the noise disappears. Narrow your color box to improve the frame rate, and then stabilize the probe to reduce movement. So let's take a look. So here's a case of VSD. True VSD will show flow moving in both diastole and systole. So this is the same VSD present, but it's showing a different cycle of the blood moving across the septal wall. So you should be able to demonstrate the shunting seen in a VSD if it's truly there, okay? Always compare grayscale versus your color flow. Always compare, and then you want to show your VSDs in 2 planes, apical, basal, or so forth, not just, you have to confirm it in 2 planes, usually, in both grayscale and color, okay? All right. Now here's a case of your foramen ovale. It shows a shunting as well of right to left. Okay, so you should normally see that crossing through the intraatrial septum. And then I took a step further because I just wanted to know what type of waveform this will show us. And here you can see it's a nice biphasic waveform seen with the foramen, which you can see here. Nice biphasic pattern. This is all normal assessment of your foramen ovale. All right, so let's get into the umbilical vein. We have to assess the umbilical cord as well during our fetal echoes. And so We're going to just focus on the umbilical vein for this particular setting. And so umbilical vein is assessed whether to suspect placenta insufficiency or fetal compromise. Now, let's look, I guess we can look here at the artifact. With artifacts seen in this particular case, you want to core compression may mimic a high resistance. And so you definitely want to sample in different areas of the cord. If you notice allicin, PRF may be too low in this case. So sample in a free floating loop of cord, or have mom lay on her side or so forth to reposition fetus if the cord is truly compressed. Raise your PRF if the allicin occurs. Okay, so we have a case coming up where I'm going to show again that pulsatile umbilical vein that we seen earlier. Okay, now this is a normal umbilical vein waveform, and this is how it should appear. Now you have to assess in both intra-abdominal as well as in free floating, okay, to compare. And you should see a normal continuous forward flow in both. Okay, so this is a normal umbilical vein. Okay, so here is that case from earlier that we've seen in the abnormal Doppler patterns. This particular case was a twin-to-twin transfusion. This was the recipient twin. And as you notice, there is some pulsatile happening in both the intra-abdominal umbilical vein as well as the free floating umbilical vein. This was not normal. So on spectral Doppler, you want to look for the waveform to show if there's some dips of the A wave, which we are seeing. And then also, we're not seeing that continuous forward flow pattern that we saw at the normal setting slide before. Now, you want to correlate this with a ductus venosus waveform, which I did. And that is where I noticed that the ductus venosus was also abnormal with reversal of that A wave. Some even appeared to be absent A wave. But this is indeed an abnormal ductus venosus seen in this same baby. And then we sent her off to have a laser treatment at a high advanced setting. And so she came back to us roughly about 10 days later, and notice we have now normal forward flow in the umbilical vein. So this was a life-saving treatment for these twins. And I must say that she did deliver 2 babies probably about 2 weeks ago. And babies are fine. So this was a life-saving treatment as far as what the babies needed. And we did take, the doctor did send her right away, right after we noticed these findings. So it was very helpful in saving these 2 fetuses' life. So if you notice any pulsatile umbilical vein after mid-gestation, that usually indicates baby heart is under stress, high venous pressure, or the ventricles are stiff. Okay. All right, so we're getting down to the end. Now we'll talk about pulmonary venous flow. And so this is where we're assessing the pulmonary veins into the left atrium. This is usually indication of left heart obstruction lesions, diastolic dysfunction we're trying to rule out. With the artifact seen, you may misidentify the left atrium inflow instead of the pulmonary vein. There may be some motion blurring. So you have to confirm the vessels entering into the left atrium, which you can kind of see here. And then with color first, if possible. I was able to see it in grayscale in this particular case. Confirm that, and then steady your probe and adjust the wall filter to reduce out the noise. Okay, so let's take a closer look in how to assess these pulmonary veins. Now I find for the right side, which we're assessing here, the apical view is best for the right assessment on the right side of those veins and arteries. And you're going to acquire this waveform where you have the right pulmonary vein, which is seen here, as well as the right pulmonary artery. And then in the subcostal view, I find that that's the best view, especially to sample for the left side, which you can see here, both the left pulmonary vein and the left pulmonary artery seen. Okay. So there's just some tips to show. Pulse wave, at least two. We sample one on the right, one on the left for every fetal anatomy scan, whether it's low or high risk. Here in this particular case is showing an example of partial anomalous pulmonary venous return. In this particular one, I could not trace the pulmonary veins or arteries into the left atrium. I only was able to see one enter into the left atrium, but the other three was instead connected to this common vessel here below the atrius here. So we did send this case off to a cardiologist, and it was confirmed to have partial anomalous pulmonary venous return. And in this particular case, actually was missed by a few other level techs because they did not routinely check for the pulmonary veins entering into the left atrium. They were kind of overwhelmed with the other heart defects, as you can see, happening within the heart, that they didn't even bother seeing if the veins were attached to the atriums, because this was a complex case of a ton of congenital heart issues within this one heart. So it was other things going on as well, but it's still, you still want to assess the entire heart, and the pulmonary veins include that in that assessment. All right, so I want to go over the waveform, the ductus venosus waveform, which you can see here, and then the pulmonary vein waveform. And notice the similarities here. So you have the ventricular cystic contraction, S wave. D has the early ventricle diastole. A showing the atrial contraction of the ductus venosus. And then for the pulmonary vein, same, SDA, but different. S, left atrium pressure reduction. D is showing the rapid fill during the left ventricle relaxation. And the A is showing or demonstrating the left atrium pressures increase during atrial contraction. But normally they both have a triphasic pattern. Okay, so in fetuses, both pulmonary vein and ductus venosus will have that triphasic pattern, but the ductus venosus, as you can see in the example, velocities are 2 to 3 times higher due to its role as that major fetal shunt. All right, so here is just some examples of an abnormal pulmonary vein. These three are cases of hypoplastic left syndrome, and you can see right away we notice the abnormal waveform seen in these three. Okay. All right, we're getting down. So aortic isthmus is one of our last ones. With aortic isthmus, this one in particular is especially helpful in growth restriction or suspected coarctation. The artifact in this particular one will be a sampling in the wrong segment, which is not between the left subclavian and ductus arteriosus or alicin. Fixed tip, confirm your anatomy. Make sure you're in the right place before placing the gate. Increase your PRF to get rid of the alicin and switch the PRF mode if the alicin persists. Okay. It's a beautiful example. You can see of aortic arch and IVC, SVC. Right. One thing to remember, any retrograde flow, it will indicate some kind of compromise going on. Okay. All right. So here's that case of that coarctation that was seen from the first trimester. We followed to the third trimester. You want to place that sample volume distal to the neuron, usually in that descendant aorta. You want to identify continuous forward flow or sawtooth waveform, confirming there's obstruction. Okay, I went too fast. So just keep that in mind when you're assessing for aortic coarctation. All right. The 3VTV is ideal view for your right aortic arch anomalies. This one in particular, however, if you have your color Doppler, it's really helpful in assessing and showing the U shape instead of the normal V shape seen of those vessels. So here's an example of a right-sided aortic arch, and it's showing that U shape. Okay, and that's all assessed through with that color Doppler. Okay, now with the aortic isthmus, fetal isthmus flow, you want to assess it as seen here. The best view is with the 3-vessel trachea view. Okay, now this one in particular will reflect the balance of blood flow between the cerebral circulation, systemic, and placenta circulation. Now in healthy fetuses, your normal antegrade flow, and that should remain stable throughout gestation. Okay, and then here's a normal waveform of the aortic isthmus. All right, now once again, if you notice that there's reversal, that is not good usually. Okay, so before we even get to the color, you want to assess the size of the vessel, which we can see it is at narrow. Once you apply the color, we notice that there is some reversal. That's usually a warning sign. It may be indicative of a severe IUGR or failing fetal compromise or compensation. Usually they start prepping for delivery. Signals reduce oxygen delivery to the brain. It could be a late marker of compromise. And so usually the doctor may assess or send patient to L&D maybe to get delivered. Okay. Now, just use this reversal that you'll see in this isthmus as the last warning light. Look at it as your check engine light for the fetus on the fetal dashboard. So forward flow means that the system is coping. Reversal means that warning light is flashing, and so urgent action needs to take place. Okay. Go. All right, so I'm ending here just with some points to remember. Use color Doppler first to localize those abnormal jets or turbulent flow. Align your sample gate parallel to the flow for accurate velocity. Evaluate your waveform patterns and direction. You want to confirm those shunts or obstructions. You want to assess your flow direction. The waveform shape is important to classify the lesion. Recognize your ductal dependent lesions. That's usually with those reversals in cases for hypoplastic left or pulmonary atresia. Combine your grayscale with your Doppler to get that complete hemodynamic picture, and then evaluate your spectral Doppler waveform direction and shape to identify those shunts and obstruction. Very, very important. Okay, I am all done. I hope that you guys learned something. I do want to say that Paul already talked about my workbook. My workbook is very helpful in these cases because it has like activities throughout the book to really help you tackle on, especially what we talked about today. And then if you're really close to taking your boards or considering it, the prep questions are very, very, very helpful in helping assess what you're learning. But I'm all done, Paul.
Right. Thank you so much for
Yeah,
a
no
wonderful
problem. I'll stop sharing.
presentation. That is a whole lot of information. I wish I had this webinar before my exam. That is a whole lot of information. Thank you so much.
No problem.
I just hope most of our participants are able to pick, because most of them are not really practicing fetal echo, and it's really a whole lot of information to say. Thank you so much, Lashell, for your wonderful presentation. So I would love to have Mr. Mahmoud present to us on the outflow tracts and the anomalies.
Thank you, Paul, for the kind invitation and kind introduction as well. And I really enjoyed the presentation by Lashell. It's really, really nice and plenty of information. I personally enjoyed it so much, and I think that is very informative and very simple as well, although it has a lot of really complex cases. So thank you for this. I think the Lashell presentation actually was a very good introduction to what we will actually start touching on, which is the three-vessel trachea view, the understanding of Dopplers and different views and different application of the ultrasound machine is really important for discussing the different heart plane and actually how to examine the fetal heart. Let me share my presentation with you guys. Can you see my screen now?
Yeah, sure. We can see that.
Great. So we will talk about the three-vessel trachea view, which is part of the heart examination that has been, I would say, recently introduced. Initially, in majority of the screening protocols, the major heart structure was assessed via the four-chamber view, which actually can exclude about 50 to 60% of major heart problems. But the three-vessel trachea view has been recently introduced, and actually it did show a significant improvement in detection of congenital heart disease. So what we will talk about today is the normal three-vessel trachea view and what is the checklist that you want to look for. And we will go through some examples of the abnormal views. If you want to examine the three-vessel trachea view, there are four main things you need to look at, which is going to be the number of the vessels you're seeing in that view, the size of those vessels and how they are arranged, and the flow into these vessels. And we'll go through this in a second. So this is what you get in a three-vessel trachea view, and the three-vessel trachea view is just a view above the four-chamber view. So if you are using your transducer at the axial view to look at the four-chamber view, if you slide slightly higher up and slightly oblique, you'll start seeing this nice three-vessel trachea view. It's three-vessel trachea, so from its name, it has three vessels and it has the trachea. And as you can see, from left to right, you should see the pulmonary artery transforming into the ductal arch, and then the aorta going into the aortic or transverse aortic arch and merging as a V shape on the left side of the trachea, and the trachea actually on the right side. And behind the trachea, you can see sometimes the esophagus as well, just in front of the spine. And then on the right side of the aorta, you can see the SVC or superior vena cava, and that is what you usually get in that view. You will appreciate that the pulmonary artery is slightly larger than the aorta, and the aorta is slightly larger than the SVC. In a lot of new machines now, you can, if you get the right plane, you can actually measure those structures, and you can get reference for the Z-score for the diameter for all these structures. So you can actually get to know whether it's the right size or not. But by eyeballing, this is what you should be expecting in that view. So let's start by number. If you've got an abnormal number, then you start thinking why you get an abnormal number. So you can get more than 3 vessels, or you can get less than 3 vessels. If you get 4 vessels, then you think about a couple of things. You either have 2 SVCs, or there is an ascending vein from a total anomalous venous return. If you've got 2 vessels, then most likely you got a transposition of great arteries, or a common arterial trunk, or in some cases of tetralogy of Fallot as well. So let's see some examples. So if you look at the image here, you can see that in that view, there is another vessel on the left of the pulmonary artery, which you shouldn't be getting. So actually you've got an SVC on the right, but actually there is another small vessel on the left. So these are 4 vessels here. So these are 2 superior vena cavas, or what we call a persistent left superior vena cava. The superior vena cava, the left side, usually become atretic in majority of fetuses, and you should not be seeing them during normal cardiac examination. There are some clues for the diagnosis. If you see a 4th vessel, then maybe if you slide slightly to the pulmonary artery or the right outflow, you could see the vessel slightly more clearer, so you can see it slightly bigger if you're thinking there is an artifact. And in the 4-chamber view as well, you can look at the 4-chamber view, because in majority of cases, this extra vessel or this left superior vena cava usually drain into the coronary sinus, and actually you can see the coronary sinus dilated on this image. As you can see, it can be slightly misleading sometimes, and you think there is that's the valve, but actually that is not the valve, that's a dilated coronary sinus. So the persistent left superior vena cava, just few information about it. It's one of the most common variants actually in the systemic venous return problems. It can happen in up to 0.5% of normal live birth, but it can be associated with congenital heart disease as well. That's why we have to be really thorough in examining babies when you find the bilateral SVC. It can be associated with heart disease, especially the left outflow. So if you've got an SVC, it's our protocol in our center to see those patients later in pregnancy to check the left outflow. It will usually drain into coronary sinus, as we said, but it can drain directly into the left atrium. And this is usually when there is a hole or there is a defect into the coronary sinus, usually. So technically, it is still draining via the coronary sinus, but it's open on the left atrium in those cases. So always think about the left outflow and the dilated coronary sinus, and we'll see why we're really stressing on this. So when we see patients with bilateral SVCs, we want to really rule something that is more serious and more important, and it can give you sometimes 4 vessels, which is the anomalous venous return, which is a completely different and a very serious cardiac condition, unlike the bilateral SVC. You want to rule out the other structure anomalies, and we always repeat the echo in the 3rd trimester in those cases. If it's an isolated bilateral SVC, we usually reassure the parents, and we say that is a normal variant. We do not usually offer them invasive testing if it's isolated, and we would just repeat the echo after birth. Remember, you have to rule out the anomalous pulmonary venous return, and there are 2 golden rules for checking the pulmonary venous return which is easy actually and simple to do. So you can either check the pulmonary veins, at least one on each side. So you want to see one pulmonary vein entering the left atrium, one on each side at least. We all know that there are 4 pulmonary veins. If you can see one entering the left atrium on both sides, and as Lashell said in her nice, lovely presentation, the use your Doppler. So if you want to see those vessels, these are slow vessels with slow flow, so you can use your power Doppler, or you can reduce your PRF. And there is a very useful tip as well, which actually can be detected in even a 2D scan, is the distance between the aorta and the heart, the area between the heart. The area between the heart has been studied recently, and there is a lot of publication on this. If you've got a big distance between the aorta and the heart, or the back of the heart, this makes you start to suspect that there is an abnormal venous return, or abnormal return into the left atrium. Then we can take another example of the abnormal vessel number, which is the transposition. The transposition is about 5% of live birth with congenital heart. It is the second most common cyanotic heart disease. We all know that tetralogy of Fallot usually is the commonest. It's rarely associated actually with extracardiac problems or genetic associations. There are 3 types. There is the TGA, which is the most common. And there is the LTGA, and there is the congenitally corrected TGA. So TGA simply is where there is concordance between, disconcordance between the great vessels and the ventricles. So the aorta will come off the right ventricle, and the pulmonary will come off the left ventricle. The commonest type, as we said, is the classic, or the DTGA. And it's good to know that actually boys are more common to get this anomaly, and also infant of diabetic mothers would be at high risk. Here is an example of the TGA, and if you can see in this clip, if you swipe across the 4-chamber and go to the 3-vessel trachea, you'll see only one vessel there in the view, which is beside the superior vena cava. So the reason you get one vessel and not the 2 vessels, that they are aligned on top of each other. So actually you see only one vessel in that view, but actually both vessels are there. But because in that view you are only seeing one vessel, the other one is just behind it. And that is a clue in diagnosis, which is very easy actually to pick up, and much easier than getting other views, which is typically this one. If you get a sagittal view or a slightly oblique view, you start getting the typical appearance of both vessels running parallel to each other, which is not very easy. You always get what the fetus offer you. So if you can get the 3-vessel trachea view, that is the easiest to diagnose the TGA. The TGA is associated with other problems actually. Intracardiac, the commonest is the VSD, and actually it is important to check whether there is a VSD or not with the TGA. But there are other problems. The outflow obstruction sometimes is associated with it, and again, it's mainly on the left side. What do we do when we find the TGA? We always assess the patency of the foramen ovale and the shunting pattern, as Lashell explained. That's very important in fetal circulation, and actually it's even more important for those babies, because it is very important for mixing the blood. And if there is a VSD, we always want to assess for the left ventricular obstruction. Those babies are dependent on prostaglandin after birth, but it is variable. So it all depends on how is the outflow in those babies. If there is pulmonary stenosis or coarctation in the aorta, or if there is restriction across the atrial septum, then the prostaglandin will be needed after birth. So that's why it's very important to assess the atrial septum and the foramen ovale, because if there is a lot of restriction, those babies actually might require immediate intervention after birth. So that is very important as well in planning where to deliver those babies. Then we move to the next item, which is arrangement. So we mentioned in the arrangement, you would expect from left to right, you're expecting the pulmonary artery, you're expecting to the right, on the right side of it, the aorta, and in the most right, you expect the superior vena cava. So you should get, ideally, left duct and arch. But what you can get a lot of other variants. You can get a right duct and arch, you can get a left duct and a right arch, and you can get a double aortic arch, actually. So let's go into this in more detail, and do not forget that also we've got what's called an apparent right subclavian artery. We'll go to this, and why I mentioned this here, because it is relevant to what we will discuss in a second. So that is the arrangement that you would expect in an abnormal view. So we shared the normal view before, where the V will meet on the left side of the trachea. So on those example here, you can see that actually there is U shape on your left hand side, and there is a V shape in the middle, and there is another U, but actually there is a vessel encircling the trachea, actually, on your right hand side. So in all those images, the left is, as you can see, the left is on the left and the right is on the right. So what are those examples then? If you see those images, if on your 3-vessel trachea, if you see the one on the left, that's a right aortic arch, and the duct is on the left, as you can see. If you see the one in the middle, that's a right aortic arch, and the duct again is on the right as well. If you see the one on the right side, that is a double aortic arch, and actually the vessel in front of the trachea is the atretic, or the smaller branch of the or the smaller aortic arch. So the aortic arch will have two, one on the right and one on the left, and usually the one on the right is usually more dominant. So sometimes you cannot really see clearly the left one, and we will go through this in a second. In practice, the most tricky I always find is the one in the middle, actually, to diagnose, because you can easily miss it. If you do if you look at the 3-vessel trachea and you see a V, you get reassured and you say, well, that looks normal. Let's carry on with the rest of the examination. But actually, this is abnormal, because this is a right arch and duct. So actually, that is an abnormality. So always be careful from your left and right. The abnormalities of the aortic arch actually is more extended than what you think, and there are various types. And this very nice article on the IUGR just tells you about all the different possibilities that you can get with an aortic arch, and actually you can see there are multiple here. The significance of these anomalies, actually, in two things. This is the association with other heart problems and the severity of those abnormalities, but also because this aortic arch is lying in a critical part of the baby chest. So some of those lesions or some of those anomalies might form what we call a complete ring. And the significance of this complete ring, that it might cause constriction in the either fetal or other baby swallowing or breathing after birth. So that is very important to know as well. So it can form a complete ring, constrictive ring, or it can be an incomplete constrictive ring. Let's move to one of them then. This is a right aortic arch and left duct. And as you can see in this view here, that's a U shape instead of the usual V shape that we would expect. It is associated with other congenital hearts, especially things like tetralogy of Fallot or truncus. You'll get extracardiac anomalies, and that's why you really want to examine the fetus carefully, and also risk of congenital anomalies. And babies with right aortic arch and left duct, we typically offer them invasive testing. The most common, obviously, chromosomal anomaly you can encounter with those babies is usually 22q11, or what used to be called cri du chat. We do not call it this anymore. In this clip here, you can see the two vessels are encircling the trachea, so one on the right and one on the left, which give you the typical appearance of a U-shape appearance. So if you keep sliding to the top, so if you go higher up from your three-vessel trachea view, you will see the subclavian artery. And why I'm sharing this, because you will need to see the subclavian artery as part of your heart examination. And here, as you can see, the subclavian artery is going behind the trachea. You should, in all normal fetuses, as a rule of thumb, you shouldn't get any vessels running behind the trachea. If you get a vessel running behind the trachea, then this is an abnormal course. And here in that baby with the right aortic arch and left duct, you would get an apparent left subclavian artery. And again, this forms a substrate of a constrictive ring. What about this view? Can you look at this view and tell me, what do you think? That's a three vessel view. And if you look at the first glance, you would say, well, that looks like a right aortic arch. Well, let's do more examination. And if you see in this clip, you can appreciate there is another vessel that comes into the view, which just crosses in front of the trachea. And if you put the power Doppler, you start getting this tiny vessel view in front of the trachea, and actually this is a double aortic arch. So always be careful. The right aortic arch can be sometimes misleading to a double aortic arch. So always check the plane clearly. Obviously, there are other clues for diagnosis, and you can actually get other sagittal views or other views to confirm your diagnosis, but it's as simple as this. If you see a U shape, make sure you're not missing a double aortic arch, because it has a different prognosis, and it is a complete ring, and it actually can cause problems after birth. And as we've seen with Lashell in the previous presentation, it's how you use your machine, how to optimize your views, and how to use all your tools, including the different types of Dopplers. And then we move to the next part, which is the flow. So what you would expect antegrade flow or forward flow in all your vessels. So if you get an abnormal flow, if you get a retrograde flow, then this is something that is a clue for diagnosis of heart disease. You can get retrograde flow in the aortic arch in things like hypoplastic left heart or hypoplastic aortic arch. You can get retrograde flow in the ductus, in the pulmonary stenosis, and in the tetralogy of Fallot. Or you can get an abnormal flow behind the trachea, as we explained, and this can be the apparent right subclavian, and we'll go through this in a second. That's why I told you, always be careful with the apparent right subclavian, because although you get a normal three-vessel trachea view, and you can see the arches meeting nicely on the left side of the trachea, look behind the trachea, because you might get this vessel isolated, which is the case actually in majority of the cases of apparent right subclavian. So that is a sweep across the baby's heart, and starting from the right outflow going up to the 3-vessel trachea. And again, in the first instance, you look at this and you say, well, that looks nice and normal. Both vessels are crossing, and the 3-vessel trachea is normal, and the pulmonary valve looks nice, and the size all look good, isn't it? But you do an extended examination and you put your Doppler, and immediately you realize you would have missed the vessel going behind the trachea. And here, as you can see, we've put the PRF low, so we would be able to detect this vessel because it's a small vessel, and if you put the normal Doppler, you might not get it in some views. This actually was a patient with high BMI as well, and anterior placenta, which makes the examination even more challenging. But you would have missed this if you not used the color Doppler or the power Doppler. The apparent right subclavian is fairly common, I would say, and it's usually isolated. It's a benign condition in majority of cases, but it still can be associated with other congenital heart. There is slight increased risk of trisomy 21, and it's an incomplete ring, so it can be rarely associated with some esophageal or tracheal compression. Do we offer invasive testing for the apparent right subclavian? We do, actually, because it slightly increased the risk of trisomy 21. So we do offer women invasive testing if we find it. Then, what do you think of this one? What do you think of the flow in this pulmonary artery? You can see there is a bit of turbulence in this pulmonary artery. So what to do next? The next thing, when you see turbulence, you want to really check the blood flow. You want to check your velocity, because if you got turbulence and you've got the right PRF, then there is something happening. So always remember, you need to adjust your machine, or if you do not adjust your machine and you use inappropriate PRF, you will get a lot of errors in your examination. But here, once you put this and you check the velocity, you can see the velocity here is reaching up to 200, which is completely abnormal. You would expect anything, as a rule of thumb, you would expect anything in the great vessels less than 1 meter per second throughout gestation. You might later in pregnancy, yes, you might expect in the bigger vessels up to 2 meters per second, like ductus arteriosus. But as a rule of thumb, when you examine, because majority of us will examine the fetal heart around the time of anomaly, which is around the 20 to 22 weeks, you would expect the velocity across aorta and pulmonary to be less than 1 meter per second. And here you can see it's almost reaching 2 meters per second, and this is abnormal flow. Then that is that's telling you that's pulmonary stenosis. And the problem with the obstructive lesions, especially the pulmonary stenosis, it is something that is difficult to diagnose. Those lesions, especially when they are mild, they are subtle, and they typically develop late in pregnancy as well. So pulmonary stenosis, majority of it is diagnosed postnatally. But actually, it is a serious cardiac problem. And if it's gone missed and those babies delivered outside centers without the diagnosis, the mortality rate will be very high. So it's up to 5% of congenital heart disease. The pulmonary stenosis actually can be either functional or structural. And if it's structure problem, it's mainly the valve itself. Although you can get problems either below or above the valve. It can be very mild, which is most probably you're not going to be able to diagnose it during pregnancy. The critical ones, you should be able to get them in pregnancy if you do the right thing. You can get functional stenosis in the valve, and this is particularly relevant if you look after twins, the monochorionic twins, because it's in complicated twins or twin-twin transfusion, you will get right flow obstruction in the recipient, actually. And if you see a lot of twins, the cardiac changes actually happen before the classic twin-twin transfusion. The very old classification of Quantero staging for twin-twin transfusion does not take cardiac examination in account, but we have contributed in few studies that actually that showed that the cardiac function should be an integral part of assessing monochorionic twins. And some of them actually will show cardiac compromise before they start showing the classic TTTS problems. Then we move to the next part of the assessment, which is the size of the vessels. Which sometimes is the most striking, because you look at the three vessel view and you say, well, this looks really abnormal. But it can be very subtle as well. So always remember, the pulmonary should be slightly larger, then followed by the aorta, followed by the SVC. And this is just by eyeballing should be enough. We do not usually routinely measure the vessels in all our examinations, unless we suspect that there is discrepancy. So if it's a small vessel, then think about the coarctation, hypoplastic heart in the aorta. If the pulmonary is small, think about the stenosis of the artery or the tetralogy of Fallot. But the vessel might be big, and again, the big vessel might be just a post-stenotic dilatation, or it might be a big vein. The superior vena cava might be dilated in the anomalous venous return. How would you know if the vessel is big or the other vessel is small? This is a bit of a dilemma, and sometimes it makes it a bit difficult for the diagnosis, but always remember, we do not examine the planes, we examine the heart, and always use this as a way of thinking when you're doing heart assessment for the baby. We do not examine planes, we examine the entire fetal heart, and this will make you reach the diagnosis much easier. So let's take this example here. In this three vessel trachea view, you can see that the aorta is considerably larger than the pulmonary artery, and the aorta is almost as the same size as the SVC. And you can see there is a bit of turbulence at the aortic flow as well. And if you can see, there is barely any flow in the pulmonary vessel. Again, always be careful of the wrong way of using your color Doppler, because we are on axis here, we're not off axis, so there is no flow across the pulmonary, and we are happy that this is an appropriate assessment. If you are off plane, so if you are not using the Doppler in the right way, then you might sometimes falsely diagnose that there is no flow across the vessels. As a rule of thumb, if you want to check flow by Doppler, you should be at right angle of your vessel. You should be, the flow should be directly parallel to your vessel. So you should be seeing the flow going either from the top or the bottom, but you should not be perpendicular to the vessel, or you don't get the proper flow by the Doppler assessment. So we're here satisfied that actually we are not off axis, and actually there is minimal flow going through the pulmonary vessel. But the arrangement is fine, everything otherwise fine. So what do we do next? We check the rest of the heart. And here, if we start checking the rest of the heart, you could see clearly there is an aortic override, and there is this turbulence is most probably because of the excess flow coming from both vessels, from both ventricles. And this is a tetralogy of Fallot, and there is pulmonary stenosis. That's why you could barely see the pulmonary, and the aorta appears a bit bigger. Tetralogy of Fallot is the most common form of cyanotic heart disease. It's a combination, actually. It's a tetralogy, but during pregnancy, when we diagnose, you only see 3 of the 4, which is the pulmonary stenosis, the VSD, and the aortic override. It's highly associated, obviously, with chromosomal anomalies, and we offer them all invasive testing. There are associated problems in intracardiac, including the right aortic arch. So you get abnormalities in the arch in this particular heart problem, but you can get other problems as well, which you can see SVC, persistent left SVC, or AVSD. Then what about this one? If we move to a different example, now in this 3-vessel view, you can see the pulmonary is slightly bigger than the aorta. Again, both of them normal in shape and normal in position. And you move straight to different views, and you can appreciate in this 4-chamber view, the right side of the heart is dominant. You can see that the left side is smaller. And in the short axis view as well, it's very obvious how small the left side compared to the right side. And immediately you think about checking the arch. And here you can see that the arch, aortic arch, is hypoplastic as well, very tiny. And this will tell you that this is a hypoplastic left side with evolving coarctation as well, which is very important because you will most eventually get those left side problems are always connected to each other. So you start with something and you end up with the whole pathology. And it's important because you need planning for this. You really need to know what is the outcome of the disease. Is it going to stop at some point, or is it going to keep progressing? Because everyone has different prognosis and different surgical procedure. In summary, 60% of congenital heart actually you can check by 4-chamber view, but we include the 3-vessel trachea because it significantly improve your detection rate. Examine the heart, always examine the heart. Do not just examine planes. Use clips, and sine loops as well. Do not really only use images. Try to see in slow motion. Remember, the fetal heart rate is just going very quickly, so always stop and reassess more than once. Use the color Doppler and adjust your PRF all the time. Why we're doing all of this, why the 3-vessel trachea view important? Because it can increase your detection rate up to 90%. And it can rule out duct-dependent lesions. Duct-dependent lesions are very serious, and they can be managed by one simple thing after birth, which is the prostaglandin. If you give those babies prostaglandin to keep the duct open, you save their lives until they have the surgery. Or at least until you transfer them to a center if you haven't planned this prior to delivery. The 3-vessel trachea view can diagnose a lot of heart disease. As you can see, the TGA, tetralogy of Fallot, hypoplastic left heart, almost all the anomalies of the aortic arch, and the anomalies of the venous return. So it's very valuable heart view, and it's very easy to get. Just touching on few things, not all the views that you see in the 3-vessel trachea view are abnormal. So there are some normal variant, and you have to be a bit careful with those. So here is an example. That's a slightly dilated pulmonary artery, and as you can see, compared to the aorta, so there is a discrepancy between both vessels. But when you check the flow, actually the flow and the velocity across the pulmonary artery is normal, and the rest of the heart examination is normal. So again, that is not an abnormal finding. You sometimes get a normal variant of a slightly dilated pulmonary artery as long as you get normal flow across the valve, as long as the valve leaflets look normal, as long as you do not see any other cardiac anomaly, then this is a normal variant. Also, what do you think about this one? You can see a vessel just behind the trachea, which is going to the superior vena cava, and this is sometimes we get referral of these views as an apparent right subclavian, but this is not the subclavian. This is the azygos draining into the superior vena cava, which if you have got machine and you've got a slim patient, you can see it actually in the 3-vessel trachea view. So that is a completely normal variant. And here is another thing. I didn't have a clip for it recently, but we see it quite a lot, but we do not really take a lot of clips for it. That's a normal variant as well, which is the tortuous pulmonary tortuous ductus arteriosus, and sometimes might be slightly dilated as well, which we call an aneurysm of the ductus arteriosus. The tortuous ductus arteriosus, especially in the 3rd trimester, is a completely benign and normal variant, and we wouldn't necessarily do anything different when we see it. So again, that's another normal variant you can get in your 3-vessel trachea view. So this was just an overview about how to use this very simple and useful plane in your cardiac assessment for the fetus. Always think about the heart and examine the baby's heart and not the planes, and adjust your machine, and you will get most probably a very good detection rate for your cardiac examination. Thank you today for joining and listening, and I'm very pleased to be with you all today.
Thank you so much, Dr. Mahmoud. This is a whole lot of information, to be honest, and I'm really grateful that you honored the invitation to be here to dish out all of this. I'm really grateful. Thank you so much. And Lashell will agree with me that this is a whole lot of information too. Yeah. Okay, so I will try as much as I can to not to exceed the time we have set for this. So I'll quickly go through my presentation on the 4-chamber view. Although I would have loved sharing that first, but I need to have Lashell and Mahmoud present for us first before I do that. So let me try share my screen. Okay, so from the beginning. All right, so I'll be speaking on the fetal 4-chamber view, the standards and the anomalies. I'll quickly move into the outline where we'll be looking at the embryology, overview of the embryology, and we'll look at the structural assessments, we'll look at the functional assessments, we'll look at how to actually obtain these 4-chamber views in respect to your structural and functional assessments, and we'll look at some selected anomalies because of time. So the embryology of the fetal heart actually starts from the 3rd week and runs through the 8th week. And in respect to how the heart develops, it starts first from the cardiogenic area being formed at the fetal pole. We have the head and the tail. You can see my arrow. So it starts from forming at the middle, at the eccentric part of it. And then at the 15, it starts forming into what we call the cardiac crescent, where we have the first field heart and the secondary field heart, the second field heart. So the first has leads to the development of the ventricles, and while the second field heart leads to the development of the outflow tracts, the pulmonary and the aortic heart. So at the 28th, you start having what we call the endocardial tubes start forming, where you have this part where my arrow is being the sinus venosus and the upside being the arterial venosus. Here, the sinus venosus is where the blood goes in, and this is where the blood flows out. So at the 21, you have the endocardial tubes being formed, and you have what we call the primitive heart tubes. And the primitive heart tubes are being divided into 4 areas, where you have your truncus arteriosus, the bulbus cordis, the primitive ventricle, and the primitive atrium. So when it gets to day 23, these truncus arteriosus will start developing into the truncus, the pulmonary truncus and the aortic truncus, while the primitive ventricles will start developing into your right and left ventricles, and the primitive atrium will start developing into your right and left atrium. And also the sinus venosus, like I said earlier on the 28th, also contribute in the development of the atrium. So when it gets to the 28th, you start having the heart being positioned. However, on this day 25, we will have to express what we call the looping of the heart, where the heart loops to the right and not to the left, because when it loops to the left, you are expected to have an anomaly during the development. So in the 28th, you have the positioning, you start having the septum forming and the heart being formed into its different chambers, which on the 80th week, we are expected to have the heart fully developed, and on the 28th, the heart will start functioning in respect to pumping. Beating, that's when you'll be expecting the heartbeat. So when we come to the overview of the normal 4-chamber view, it is very important that we know that the procedure for imaging the fetal 4-chamber view should be consistent regardless of the position of the baby, of the fetus, of which the fetus could be cephalic supine, cephalic prone, bridge supine, bridge prone, or transverse. No matter the position, it is very, very important that the rules are being maintained. And the heart's most critical section that gives us precise evaluation is the 4-chamber view. And the 4-chamber view gives us mostly the congenital heart defects that we are expected to see. About 60% are being expected to be seen on fetal 4-chamber view, while you have 40% seen in the outflow tract and the 3VT. So when imaging when evaluating the fetal heart, it is very important that you take it in a systemic way for you not to miss out anything. The fetal 4-chamber, you start first by imaging the abdominal situs and the laterality. Here you have to verify the visceral organs, how they are lying. We'll look at it. You also look at the laterality, which is the presentation of the fetus. You also look at the heart size, the position, the chambers and valves, the cross foramen oval, and the function. So when the apical view, as you can see on this image, is actually the ideal way to image the heart. However, you can still image the heart when it is not in apical view, when it is back up, when the apex is down, or when it is lateral, when the apex is sideways. So I just played this video for better understanding. So this is a apical 4-chamber view. You can see the apex, and this is the lateral, where you have the lateral 4-chamber view, and this is the backup view when the fetus is lying prone. All right, so let's start. In imaging the fetal heart, you first have to start with your abdominal situs, and that is when you first of all bring out your landmarks for your AC, taking the abdominal circumference, and here you will be able to verify that the stomach and the fetal heart is on the left part of the chest of the heart of the chest, sorry. And you'll be able to see your umbilical vein. And here also you can be able to rule out proof persistent right umbilical vein. When the umbilical vein, this is the left, when the umbilical vein is crossing towards the stomach, you know that it is going in respect to proof, you'll be diagnosing proof. So when it comes to the laterality, you know that on your screen, when you are seeing the apex of the heart, when you are seeing the apex of the heart moving in this way, the apical view, you know that the fetus is lying cephalic and supine, where the baby is facing up and the spine is down. However, if the apical is back up, showing down, you will know that it is cephalic, but however, prone position. So when it is on the opposite side, you know that this is bridge supine, and when also in the backup, but on the opposite side, you know that this is bridge prone. So when looking at your screen, you will be able to actually know the position, the presentation of the fetus while doing your scan. Okay, so when it comes to the heart size, it is very important that we understand that the fetal heart size occupies 1/3 of the chest, and the heart literally lies on the left side of the chest. So in assessing, you should be able to visually, when the image is in motion, you could visually say that the heart is enlarged or not enlarged, or it is smaller than normal. However, when it is not possible for you to visually dictate, you can actually use measurement in two ways. However, you can measure using a line crossing through the valves from the right to the left, from the left to the right, and also from the other range right to the left. Or you can also use your ellipse to measure it in this way. So you are expected to have an approximate of 0.5. However, it can range from 0.5 to 0.6, but this is not a standard. There is no standard measurement I'm giving, and this is a range you could actually use in dictating if the heart is having the normal size or not. So the next is the heart position. And in checking the heart position, you use the spine and the sternum as the orientation, where you use it to actually dictate if the heart is well positioned. You can have different position of the heart. You can have it in being on the right or being on the left. You can have the apex being on the left or being on the right. You can have it in different formats. So what you should use for your orientation is the spine and the sternum. And also you should know that your left atrium is the chamber that is closest to the aorta, descending aorta, which the descending aorta is anterior to the spine. So the left atrium is the most posterior chamber lying in a normal heart, just anterior to the aorta, while the descending aorta is anterior to the spine. And you have your right ventricle lying behind the sternum. This is your sternum, and the right ventricle lies behind the sternum. And the angle by which it lies is always about 45 degrees, ranging from 25 to 70, which when it exceeds this, there is an anomaly you are to diagnose. So if you look at this video, you could see using this line, you will be able to know that this is your sternum and the right ventricle lies within 45 degrees to the sternum. Okay, so in respect to chambers and valve, you should be able to know that your chambers are to have symmetrical look, the right and the left ventricles, the right and the left atrium. One might be wondering, how will I be able to know which one is the right ventricle and which one is the left ventricle? So one of the things you should know to use and distinguish the right ventricle from the left ventricle is the presence of what we call medulator band. So the medulator band, as you can see, my arrow is located on your right ventricle. And also you can see that the walls of the right ventricle is not smooth. So it has a trablocated walls that is not smooth, while the left ventricle has a smooth wall and cone shape, and there is no moderator band in your left ventricle. And you say that the right atrium and the left atrium, the best way to distinguish is that the left atrium is the chamber closest to the posterior to the aorta, that is anterior to the aorta, and the aorta is anterior to the spine. So you could be able to notice quickly that this is the left atrium because of the descending aorta and the spine. And also you can be able to rule this out using the valves, where you know the valve connecting the right atrium to the right ventricle is a tricuspid valve, and the valve connecting the left atrium to the left ventricle is the mitral valve. While looking at the chambers and valve, you should be very much concerned with the placement of these valves, the tricuspid valve and the mitral valve, of which the tricuspid valve is located a bit above the mitral valve. So you also have to check the sizes of these ventricles to be sure that the two atria has approximately equal size and the two ventricles also have approximately equal size. So the heart, you will also notice small fluid collection, which is the pericardial fluid. So when it is small, it is normal observation. So this is a video showing the moderator band, the mitral valve, the tricuspid valve, and the pericardial effusion. So this is one of the ways you could assess the chambers and the valve. So the image here helps us to notice this is the moderator band. If you cannot see it very well here, so this is the moderator band, and this is your ventricular septum. This is the cross, the center of the heart, and this is the tricuspid valve. This is the mitral valve, and this is the arterial septum. And the left atrium gives to the pulmonary veins, the left and the right pulmonary vein. So we'll talk about the cross. The cross is the junction of the arterial and the ventricular septum, and also the septal leaflets of the mitral and tricuspid valve. So the center of it is what we call the center of the heart, or the endocardial cushion is what we call the cross. And when it comes to the insertion, the tricuspid valve inserts while imaging the cross. You should know that what I mentioned earlier on, that the tricuspid valve, which is located at the right side of the heart, inserts more apically than that of the mitral valve. Okay, if you look at this, you could see that this is being attached higher than the mitral valve. So when they are on the same level, you know that there is an anomaly that you should be looking at. So this is a clear image bringing it out. You could see that the tricuspid valve is attached apically more than the mitral valve. So this is the normal cross having this attached higher than that of the mitral valve. So we'll look at the foramen ovale, which is one of the shunts that occurs in utero. I think Lashell mentioned about the ductus venosus, which is one of the shunts that connects the umbilicus to the inferior venous cava, and then the foramen ovale connects the right atrium to the left atrium, where the flow is from the right to the left. And the third shunt that we have, which is not here, is the ductus arteriosus that connects the pulmonary trunk down to the descending aorta. All right, so the foramen ovale, like I said, is the ventricular, is what connects the right atrium to the left atrium. So the lower part of the arterial septum, which we'll call the premium septum, in the development, actually, which I didn't mention, the embryonic development, you have the first thing that forms in the dividing of the atrium as the septum premium. So the septum premium grows to the endocardial cushion, and where it joins to divide the right atrium from the left atrium. However, the septum secundum also continues to grow, and before the septum secundum comes, there is always an opening, which is the first opening that occurs between the septum, between the closure of the right and the left atrium. So the septum secundum comes and closes it, and then gives rise to that of the foramen ovale. So there is a defect in the middle third of the arterial septum. That is the foramen ovale, which is guided by the foramen ovale flap. So this is the flap that guides it, which lies in the left atrium. So the flap always lies in the left atrium. So in the functional assessment of the fetal fourth chamber, you will be looking at the contractility of the two ventricles, how they are contracting. You also look at that of the atrium, how the atriums are contracting. And you should be able to look at the valves, which is the mitral valves and the tricuspid valves, how they are opening, if they are opening equally and freely. So if you look at this video, you could see, you will be able to check how both ventricles are contracting, how both atrium are contracting, and you also check how both valves are opening. So these are things to assess when it comes to the functional assessment, aside the things that Lashell mentioned when we are talking about, this is 2D, when we're talking about color Doppler, you also assess the functional aspect of it in respect to color Doppler. So we want to talk about how you'll be able to obtain this four chamber view. And in obtaining them, we look at it in two ways, where we talk about the transducer manipulation, and then we also look at it in respect to the landmarks. So in your transducer manipulation, we have the in-plane, which I abbreviate as the SRP. You have your sliding, your rocking, and your pressing. So the sliding, this is what you use to move to the thorax into the center of the scan plane. So you use it to be able to move the thorax to come to the center of your imaging plane. And the rocking is from side to side laterally. So this can help you to produce a better image by avoiding shadow or by rotating the thorax to an improved orientation. So it helps you to remove shadowing, and the pressing down on the abdomen helps you to displace if there is any bowel between the abdominal wall and the uterus, or to bring the fetal thorax closer to the transducer. So in imaging this, it's very important that you allow some amniotic fluid to be between the thorax and the placenta or the uterine wall. So this is what it means when you are sliding your probe. So you could see when you slide, the fetal thorax is either out of the plane or in the plane. So this is rocking, which you use in terms of removing shadows, and this is pressing to displace any bowel gap, any bowel between the abdominal wall and the uterus. So the out plane, in the out plane, you have the HRA, where you have your horizontal movement of the probe. In this aspect, you are moving it to bring the fetus in line, and this can be used to obtain series of parallel slices, starting with the four-chamber, the transverse views of the great arteries, and arches can be obtained. So your horizontal movement helps you to move from one view to the next view. And the rotation of the transducer can also help you to visualize your left ventricular outflow tract, the outflow tract. So when you rotate your probe, when it is on the transverse in plane and you are doing out plane and you rotate it 90 degrees from the fourth chamber, if you're on the fourth chamber view and you're rotating it 90 degrees from it, you'll be able to image the long axis or the sagittal views of the heart. So alternatively, when you rotate the probe slightly, you'll be able to view from the apical view. If you rotate it slightly from the apical view, you'll be able to open up to the left ventricular outflow tract. So the angulation of the beam can also be used to sweep the beam up and down the thorax to avoid if there is any rib shadow. So this is your horizontal movement. You could see while moving from the fourth chamber, view, it's going to the three vessel views, and in rotation from the apical fourth chamber view, you could see your left ventricular outflow tract being displayed. And in angulations, you can also use it, as I said, to avoid any rib shadows that will make you not to get a proper view. So in this horizontal view, you can see that from getting from here, which is you using here the abdominal organs, you sweep, you move horizontally. While moving horizontally, you'll be able to now visualize your fourth chamber. And from your fourth chamber, if you keep moving up, you will now be able to visualize your three-vessel views and so on. But when you rotate, in respect to rotation, you could see that this is from here before I move further away. So this can be assumed as the apical fourth chamber view, and little rotation will be taking you to part where the outflow tract is being visualized. So this is one of the ways you will be able to obtain your fourth chamber views using your out plane and your in plane transducer manipulation. So in respect to landmarks, first I want to talk about the ribs. While obtaining a standard fourth chamber view, it is very important that you ensure that it is only one rib that is showing and not two ribs. Here you could see the first rib and the second rib in this image. So this is not a standard view for obtaining your fourth chamber view. So when you see your two ribs, when you see two ribs showing, you know that this is oblique. If you look at this, so this is an oblique view where you have two ribs, and this is the perfect view where you have only one rib showing. So this gives you a perfect fourth chamber view. So when it comes to the center of the heart, it is very, very important that if you are moving your probe, if you're manipulating your probe and you manipulate your probe and you are seeing the cross where you are seeing the tricuspid valve more apical than the mitral valve, this is a perfect view. However, when you move your probe more than normal, when it goes, okay, let's say when it goes more down, when it is more down, you'll be able to see your aortic origin, which shows you that this is not a standard view for your fourth chamber. You will not be able to access the fourth chamber view when you're seeing the aortic origin. And when you move it too high, you will be seeing your coronary sinuses. And this is not also, when you move it too low, sorry, you'll be seeing your coronary sinuses, and this is not the right plane to evaluate the fourth chamber. You could see that the left ventricle appears to be bigger than the right ventricle in this image when on the coronary sinuses. So this is not the right place to image. So this is a video showing you that when you are seeing your cross, you know that this is the perfect place. When you are seeing your aortic origin, you know that you are too high from the point you are meant to be. And when you are seeing your coronary sinuses, you know that you are too low where you are meant to be. So you move a bit higher to get the actual fourth chamber view. Okay, so I'll just look at some selected anomalies. So this first is what we see cardiomegaly, where the heart occupies more areas than required. And you can visualize it visually, or you can also measure it like I first described. And in this image, you could see, if you followed what I explained earlier on, you'll be able to know that this chamber here is the left. But here now, this chamber here is the left, and this is your descending aorta. So you could say that this is the left atrium, this is the left ventricle. So if you look, before I play the video, you can see the ventricular septum here, and you will see a very tiny right ventricle here, a very tiny ventricle showing you that this is right ventricle, since this is the left ventricle. And looking at it, you will see that you have a valve here, which is the mitral valve, and the mitral valve is actually opening. However, the valve connecting the right atrium to the right ventricle is not opening. So here you are talking about the tricuspid atresia, where there is blockage of the valve that connects it, and that can lead to you having this right ventricle being smaller than it is meant to be. So, and this is the left ventricle. In this case, one will wish that there is a septal defect to even help in the development of the right ventricle. Assuming there is a pronounced ventricular septal defect here, it will help in the development of this right ventricle. Okay. So this image shows you when you are having a ventricular septal defect. And when it comes to ventricular septal defect, we have different types, where we have the inlet, we have the premembranous, we have the muscular. The inlet, sorry, I didn't put that in this slide. The inlet is the one that comes between the junction of the cross and the ventricular septum at this point, while the muscular always appears at the center of the septal defect, while the premembranous is actually best visualized at the LVOT. Is the best way to visualize the premembranous septal defect is the LVOT. However, when you apply color, you will see here a color is applied, and you can see. Let me go back a bit. At this apex, you could see flow coming from the left, right atrium, the right ventricle to the left ventricle. So color assessment is very important, and Lashell was able to speak more on that. And here you have your. Sorry, I was just recording this when Lashell was speaking. So here you'll be able to see the contractility of the heart very slow. You can see the heart chambers are not beating. So this can be used to assess for bradycardia. And when Lashell was talking about the arrhythmias, so the contractility of the heart is very slow, and you could see more collection of fluid, pleural, pericardial fluids being collected more than the normal that was shown previously in the normal heart that I mentioned. So this is much pleural effusion, collected pericardial fluid collection leading to the diagnosis of pleural effusion. And this is the poor contractility of the ventricles and the atrium. So here you would you'll be able to assess the arterial septum. You have your aortic stenosis here, where you experience the left atrium being even pushing and closing the foramen ovale, because normally the foramen ovale could be closed due to high arterial pressure, but high left arterial pressure, but this normally occurs after birth, where there will be high left arterial pressure pushing the foramen ovale flap and closing it. But in this case, in utero, where you have the left atrium expanding, aortic stenosis causing it to force the closure of the foramen ovale. So, okay, so in this place we have what you have, sorry. So here you have the heart being pushed to the right as a result of hernia, diaphragmatic hernia, where the stomach and the bowels move to the thoracic region, pushing the heart to the right side of the heart, whereas you still have the apex at the left. So this is one of the things you could diagnose when visualizing your pulse chamber. And here, if you look at this, you have your right lungs and your left lung. You could see that there is nothing on the left lung. So we have your left lungs hypoplasia here, where there is absence of the left lung. So this can also be visualized on your pulse chamber view. And here on the other one, you are having both the ventricular and the arterial septum defect, the AVSD, anteroventricular septal defect, where the center of the heart, there is no connection of the septums as supposed. So this is a diagnosis of the AVSD. So the last one, okay. So this one is a case of double inlet, ventricular double inlet, where you have both the mitral valve and the tricuspid valve flowing into the right ventricle, into the left ventricle. So if you look at it, you could see the right ventricle here, and you'll be able to see that both the tricuspid valve and the mitral valve are flowing into one ventricle at this place. So, and here you have what we call the Abistai anomaly, where the tricuspid valve is placed higher than normal. It encroaches to the apical part of the right ventricle. And this can lead to the regurgitation, tricuspid regurgitation, when assessed with your Doppler. So you have the tricuspid valve orifice placed almost to the apex of the right ventricle. And in this case, this can also, you see your right atrium being large, this can also lead to cardiomegaly. So in this case, we have the mass being formed in the heart, so you can be able to assess cases of masses in the heart. This is a case of real myoma, the mass in the fetal heart. So this is a case of teratoma. This is a case of teratoma, a mediastinal teratoma. This is a case of mediastinal teratoma being indicated. So I really thank you all for coming, and I wouldn't want to go further because of time. And I thank you all for participating in this webinar on fetal heart. I don't know if I was able to contribute a little bit to the presentation. So, all right, so we'll now move into the question and if you have any questions to ask, please drop your questions so we can address that before we move ahead to the closing. If you have any question on the on what have been discussed so far, please, you can drop it. Let's address it before we call it a day. Okay. All right. Currently, I'm not seeing any question being asked in the chat. So I really want to thank Lashell and also thank Dr. Mahmoud for making out their time to be part of this presentation. And we are actually working towards helping Nigerian sonographers to be able to advance their practice. Mostly you'll find it very, very difficult to see Nigerian sonographers taking this lead in respect to having good fetal echo assessment, or even when doing anomaly, having them assess the fetal heart in the right way. So I just want, Christopher, you can ask your question. Okay, let me see, let me unmute you for you to ask your question. Christopher. Okay. All right, go ahead and
Good evening, sir.
Yeah, please, you go ahead, please. Good evening.
Thank you for a very interesting lecture. My question goes on this some of these defects, specifically on this FO, that is foreman over.
Okay.
With the early detection of this, is there any possibility of preventing it to becoming PFO?
Are you talking about the foramen oval?
Yes, sir.
The early detection of what?
Early detection of the FO, can it prevent it from resulting to PFO?
I want to understand your question. The foramen oval is meant to be detected when imaging the fetal heart. So there is no early detection of the foramen oval or late detection of the foramen oval, but I want to really understand what you mean by early detection of it. If you really understand or you need a clarification on something. Mr. Christopher, are you still with us? Okay. I don't know. I guess he didn't get his question right. If I'm not mistaken. Dr. Mahmoud, right? I don't know if you understand what he's asking for. You're on mute. Okay, you can unmute yourself.
Yeah, I didn't get the question as well. In respect to the foramen oval, as you rightly mentioned, it's part of the fetal circulation, so it should be patent, and that's why we do not usually screen for atrial septal defects or problems during fetal life because of the patent foramen oval is part of the fetal circulation, and it does have right to left shunt, which is just part of the normal circulation.
Okay, thank you very much. Lashell, do you have anything to say? No.
I guess he was asking, like, could we see well, this is what I'm assuming. Could we see if there's gonna be patent foramen, would it be any early signs? I think he was asking. And so I was just thinking to myself, like, oh, I'm not sure if we'll see anything early on before it happened. I'm trying to think in cases when it's a foramen oval aneurysm, usually there's no signs previously. We just see it. So I'm just assuming that's maybe what he was asking.
I was even looking towards the redundant foramen oval flap, if that could also be part of the things he wants to ask about, but not sure what his question might be. Okay. So please, do we have any other question? So this is we're already 32 minutes behind the schedule, and I'm really sorry for keeping you people here for this. I'm really sorry. So in absence of any question, I want to sincerely thank Lashell for her time, and also to thank Mahmoud for his time. I really appreciate you people, and I'm happy that you people are helping us to really make progress in this. Okay, Dr. Mahmoud wants to say something. Please go ahead.
I think there is a question in the Someone
Okay,
was
okay.
asking about the persistent
True.
right umbilical vein.
Okay. Thank you very much for drawing my attention to that. Like really, okay, let me just say that most times I just want to speak for myself now. Most times here in Nigeria, they just teach you that the landmark you have to obtain for you to take your AC is the umbilical vein and that of the stomach, without actually letting you know that you can actually use that to diagnose if there is persistent right umbilical vein or not. Okay, so we just bring out the AC where you are seeing the bowel, the stomach, and the umbilical vein. You don't even know whether it's the right or the left you are seeing, and you just freeze and take your AC and record that. So to the person that asked about it, this is if you bring out your AC, let me see if I can go back to that to explain further. Lashell also have something on that she taught me on. Let me share this. Sorry for taking us back. Okay. Okay. I'm trying to slide. Okay, so just using this, if you look at these, you could see your stomach, the stomach of the fetus, and you see the umbilical vein. So the umbilical vein, in the development, the umbilical vein, you have the right and the left umbilical vein, where in the development, the right is to regress during the development, and the left continues. The left goes into the liver and all of that. So in assessing your proof persistent right umbilical vein, you see that the umbilical vein is moving. Let me just use the term that will be easier. It's moving away from the stomach. This is the stomach and this is the umbilical vein moving away from it. So this shows you that this is a left umbilical vein. However, when the umbilical vein is moving opposite, moving towards the stomach, you know that it is a persistent right umbilical vein. So please, Lashell and Dr. Mu could also add something to it, please. Sorry.
Yeah,
If you have,
thank you, Paul. That's very nice and helpful, actually. So the persistent right umbilical vein in majority of cases is a normal variant, and we do see it frequently, actually. I think the significance of finding a persistent right umbilical vein, it lies in the fact whether it's an intrahepatic or extrahepatic, because they are both completely different. The commonest, luckily, is the intrahepatic variant, which is a normal variant, and it doesn't pose a significant problem on the fetal circulation. And an easy way to interrogate this during ultrasound is by checking the ductus venosus. If you can find the ductus venosus, then this is most likely an intrahepatic right vein, which in majority of cases, if you exclude other anomalies, including intracardiac anomalies, you shouldn't really be worried about it. And we do not usually offer any further testing if it's an isolated finding. On the other hand, the extra hepatic type is a problem because it bypasses the hepatic circulation, and this might have an impact on the fetal circulation, and it might cause overload. And you can actually detect this by the absence of the ductus venosus, and the vein will most probably drain into the systemic circulation, either directly into the atria or in the inferior vena cava. And this is bypassing the hepatic circulation is the problem, or the portal circulation is the problem here, because it does have impact on the fetal heart. And also with this one, you're more likely to get other structure or congenital anomalies.
Wow, thank you very much. Thank you very much. Lashell, you have something to add to that?
I was also going to mention that with proof, another good clue sometimes is the midline gallbladder. A lot of times you may notice the gallbladder is misplaced and it's in the midline. And usually that's a clue that there is a persistent rate. So I wanted to add that to it as well.
All right. Thank you very much.
Mhm.
I think I'm the one learning in this webinar. Thank you very much. So I don't know if we still have any question, because Mr. Christopher is still asking question, but I still cannot be able to pick what he meant from. His question is, can early detection of foramen ovale be prevented to becoming patent foramen ovale, if I'm right? And he said, is there any job that is hazardous to those with foramen ovale defect? So personally, I really don't get a question, and I don't know how best to address it for him. So, all right. So, Mr. Christopher, maybe you can reach out to me later on to explain further. And if I can't address it, I will reach out to them to help me address it, and I'll send it across to you. I hope that helps. So, I think that is the... Okay, somebody asked, can we know more about Ultrasound Care Foundation? Oh, Nina, sorry for keeping you people here, Lashell and Mahmoud. I'm so sorry. Ultrasound Care Foundation is a non-profit organization that is being established here in Nigeria. I'm actually the founder of the foundation, and the foundation is focusing on 4 key initiatives. And the first key initiatives is the education and training, which we are doing here to help Nigerian sonographers stay up to date with the best practices in respect to sonography, in respect to ultrasound, to enable them give more to the pregnant women, all right, like what we are learning now. And secondly, we are looking at support for pregnant women. We know that Nigeria is still upcoming in terms of development, in terms of resources. Everything is an underdeveloped country. And we have a whole lot of pregnant women who do not have access to ultrasound scan. Like the next outreach we are doing, 16th of October, we are going to a health center where we attend to pregnant women, give them free ultrasound scans that they do not have access to. So we support them, and those that do not have resources, we offer them sponsorship to carry out ultrasound scan from conception to delivery. So we offer them that sponsorship. And the next initiative we are looking at is that of annual summit. I don't know, but we have never heard of summits here in Nigeria where we come together to talk about development in respect to ultrasound, where practitioners are being taught, like the one we have about the ISUOG. And even in UK, you have conferences where they teach about all of these things, and you help professionals to update their skills. So the foundation wants to start that, of which every year we hold annual summit where we invite people from developed countries to also come and help us in advancing our skills in respect to ultrasound. So the last part is that we also offer scholarship to professionals that wants to obtain postgraduate diploma in ultrasound. We help them, those that do not have the resources, we offer them scholarships to obtain these postgraduate diplomas and certifications. Just the main aim is to make sure that maternal fetal mortality rate is being reduced drastically here in Nigeria, because over the years, we are having so much increase in maternal fetal mortality rate in Nigeria. And we have a whole lot of, we don't even have high number of sonographers. And even in the number of sonographers we have, we still don't have skilled sonographers. We still have people that do the normal without being able to go beyond the normal thing that somebody does, not knowing how to rule out so many anomalies in respect to fetal heart, in respect to obstetrics. So we just do the normal of obtaining of parameters and just digital reports. So we are trying to change a whole lot when it comes to ultrasound in Nigeria. That is basically what we do in Ultrasound Care Foundation. And it will be launching it officially in February here in Abuja, Nigeria. And the scholarship part, first batch will be taking place late next year when they start their postgraduate courses in ultrasound. While the sponsorship for pregnant women, the first batch is taking place this October 16th, and also the first batch of our outreach is taking place 16th of October. This is our second webinar in ensuring that we educate Nigerian sonographers and even those beyond within Africa in the best practices when it comes to ultrasound. So I hope that helps. So if we have anything to say, Lashell and Mahmoud, you could say so. We'll come to the end of.
Thank you very much, Paul. I enjoyed very much joining this lovely webinar, and I'm really impressed with your work as well. And thank you very much, Lashell, for the lovely presentation today. And it was a great pleasure seeing you all today. And I'll be more than happy to join for any further future webinars. Just get in touch. I'll be more than happy to join you for this really amazing work.
Thank you very much. Thank you. Asha, you have something to say?
Oh, I wanted to say thank you as well. And I really learned a lot. The teacher always is learning. I'm always learning. So I appreciate, I learned so much from you all. And I would love to join you again as well. I loved how all three of our presentations kind of coincided, from Doppler tips and anatomy and so forth. So it was a great combination of presentation materials this evening. So thumbs up.
Thank you very much. And the person that said Malawi is also benefiting. We are happy to see that all the way from Malawi, you are participating in this webinar. Welcome. That is Gibson. All right, so thank you all very much. And I will actually share, you could follow Lashell and Mahmoud. Please, you can drop your LinkedIn profile. I also dropped the Ultrasound Care Foundation profile. You can follow and stay updated with any new development that might come while we're here. Sorry, I'm trying to bring the profile out. So this is the foundations. Okay. I think this is for, okay, yeah. So you could follow him on LinkedIn, and the first I dropped is for the foundation, while the second is for Dr. Mahmoud. And you can also go to our YouTube where we'll be posting this, and help us to subscribe. I'm posting the YouTube link too. So you can go there and subscribe, and when the video drops, you can be able to go through it. All right. Lashell, I'm yet to see your link so they can access it before we end the meeting. Just take your time. Let me get that for you. Let me go to okay, I'm sending yours to yeah, I've sent yours there. Sorry.
Do you see
So
where I sent it? I sent it to you, my
yeah,
LinkedIn. Okay.
I've dropped it for you. I've dropped it on the chat box. It's on
Okay.
the
Thank you.
all right. So thank you all for participating, and we'll let you know our next webinar, which will be for month of October. Lashell,
Okay.
thank you so much. I appreciate your time. I appreciate the sacrifice.
Mm-hmm.
All right.
Thank you.
All right. Bye.
Bye. Have a good evening, everyone.
And you too.
Thank you.